I just want to go through a brief overview of best practices guidelines. So promoting peer engagement with health authorities and other community agencies can improve the involvement and uptake of peers' voices in health services planning and policy development within BC. Individuals who work with people who use drugs can use these peer engagement principles and best practices to foster meaningful inclusion, which can in turn promote positive relationships and capacity building for everyone involved and improve the relevance and acceptability of services. So the guidelines were made and PEEP was born out of the BC Harm Reduction Strategies and Services Committee that is comprised of the ministry officials, health authorities, medical health officers, and harm reduction leads across BC, tasked with coordinating harm reduction services throughout our province. The HRSS committee has been committed to engaging peers to ensure harm reduction services are equitable and meeting the needs of people who use substances. Over the past decade or so, peer engagement has been evolving and it is an iterative process. These efforts led to the development of our group, which is the Peer Engagement and Evaluation Project, PEEP, which was a research project that was built upon BC's HRSS experiences and existing relationships with peers. Our project aimed to enhance peer engagement and listen to voices that have been missing from decision-making tables across the province. The work led to the creation of the guidelines we are discussing today. PEEP methods were, PEEP engaged 7 peer research assistants, advisors, and several health authority representatives from across the province as active members of the research team throughout the project, including creation, dissemination, and revision of the document. In 2015, the PEEP team conducted 13 focus groups with 83 participants with lived experience of substance use in all regional health authorities. The qualitative data was coded by all team members and themes were derived through a participatory process. 4 broad themes determined by PEEP teams. One was societal and community readiness, peer networks, peer engagement, and stigma and trust. As you see in the diagram, it gives you a little bit of a description of what that process looked like for us. And I will turn it back over to Paul for the next slide.
Thank you, Charlene. Engaging with people with lived and living experience starts with using respectful language. Look for ways to change the narrative about how we address and speak with people who use drugs. How we can change our messaging to match the respectful tone expected of anyone else in our society. For example, number 1, use the person's first language. Don't essentialize and label us by our substance use. For those who are experiencing difficulties with substance use, maintain a respectful tone in how they are addressed. Just their condition rather than giving them a flipping label. Excuse me. For those having difficulties adapting to programs to lead to their improvement, it is on healthcare professionals to find a program to meet the person where they're at. Don't use language that asserts that people have failed. To a large extent, people's conditions are a result of society and the system failing them. So reflect that reality in the way we speak to those who do not fit within our model of care. Words like dirty and clean reinforce stigma. Now, levels of engagement. So how do we engage peers in your decision-making process? To get your program and policies to meet the needs of people who use substances, you must find ways to involve people who use drugs at every level. This slide is taken from our guideline, and it gives an example of how you can involve people who use drugs in program planning. While it is obviously essential to inform people you are serving of your plan, that is not enough. You need to have peers inform your ideas in order to know if they are going to work. better yet, involve peers and make use of their experience and expertise in your planning. So you're not sent back to the drawing board or spend a bunch of money on programs that aren't working well. Especially for larger scale policies, program making is vital to collaborate with peers from the ground up. If you're sincere in your desire to address the needs of people who use drugs, peers are aware of so many variables that you may not be that are the key of success, of programming. Collaboration is essential for consistency in meeting people's needs and buy-in from the people who you are trying to serve. So some of the most valuable programming and policy making have been the result of people with lived experience planning and implementing programs on their own. The expansion of OPS sites in BC are largely the result of people with lived and living experience taking the initiative, and I would argue the most successful sites are the ones that are run by peers because they're the ones most suited to meeting the needs of people with lived and living experience, and the ones, you know, that they feel more comfortable with. This slide is really an extension of the previous slide, which with some added elements. When you're engaging with peers in your planning process, be sure to check yourself in what you're doing. Do you need a box check that you've engaged people with living experience to get that grant, and so you put together a focus group to get that done? Then you're in exploiting basically people with lived experience. Do you have a favorite peer who promotes all your programming for you, or your engagement is limited to that? That's tokenism. Do you really want your policy making and programming to meet the needs of people who lived experience, or are you just trying to look like you're doing something about it? If it's the former, then you need to do the work and empower people with lived experience to be part of that process in a real way. Now, I'll pass it back to Charlene.
Thank you, Paul. This next slide is a little bit of recommendations on how to involve people who use drugs. You'll see some examples there. We encourage you to go toward the HEART website as well and to find the guide for involving peers. But I'll highlight some material here to get a feel of how to do this more effectively. The first point is very important. People with lived experience are not homogenous. You need to a range of perspectives. Be thoughtful on how to get their perspectives. Diversity is very important. Old, young, gender, race, as well as different drugs and lifestyles need to be a consideration. VIOC represent disproportionate rates of overdose incidents, deaths, incarceration, child apprehension, as well as barriers to healthcare and services. At times, attendees may cause barriers to engage for people with lived experience. For example, if you're hosting a meeting, it's really important to let people with lived and living experience know who is going to be sitting at the table. There can be conflicts and can cause issues for people with lived experience. If, for example, if there is MCFD sitting at the table and a person with lived experience is identifying that they are an active substance user, it could put the risk for child apprehension. Also, RCMP sitting at the table or policing, it can be very problematic for people with lived and living experience. It is important to make people feel safe coming to and sitting through those meetings. A little bit of an extension on that discussion is adjust the meeting to meet the needs of people with lived and living experience. And here are just a few examples that are shared in the BCCDC's best practice guidelines. So at times, like I've said, attendees may cause issues sitting at the table. So it's really important to be transparent to who's at the table, what the intentions are moving forward, what you're asking, and how to effectively engage people with lived and living experience. Oh, there we go. My apologies. Some other considerations are to hold your meetings in low-key settings where people who use drugs may feel more comfortable with less barriers. And it is really, really important to provide peers with stipends. Cash is preferred. You can also access the resources at the Toward the Heart website at BCCDC on best practices of peer engagement and peer payments. Help with arranging OATs and IOT carries when asking peers to come to meetings, especially if peers are traveling out of their own communities. And provide accommodations close to the meeting and space. And it's really, really important to arrange for a local, what we refer to as a substance navigator, so a person who understands the unfortunate illicit market that many people with living experience have to rely on, and having opportunities to support each other effectively with access. There can be a lot of issues around what it can look like for someone traveling to a community they're not familiar with, putting themselves at risk with a market that they're not used to, of illicit substances, also potentially being robbed, and other things that can be considerations that people with lived and living experience have to face every day in regards to this ineffective war on drugs. The last slide I'd like to speak a little bit to is some consideration of engaging peers and their safety being first. There's some clear examples here, but this can also be accessed through the information shared, once again, at the Toward the Heart website at the BCCDC. And I think that concludes our presentation for today, and I really look forward to an opportunity to answer some questions from the audience. And I will take us to the last slide. Oh, and there we go. There we go. There's some information for you. Please feel free to reach out to myself or Paul if you have any additional questions that we're not able to answer here today. But I'd like to open the floor up to some questions from the audience. Thank you.
Thank you, Charlene.